Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, The Impact of Oophorectomy on Cancer Incidence and Mortality in Women with the BRCA1 or BRCA2 Mutation, by Amy P.M. Finch et al. My name is Elizabeth Swisher, and I am professor at the University of Washington in Seattle, Washington, USA. My oncology specialty is gynecologic oncology. Finch and colleagues for the Hereditary Ovarian Cancer Clinical Study Group have reported outcomes of risk reducing oophorectomy from a large prospective international study of women with BRCA1 and BRCA2 mutations, and have made a number of important contributions which should inform preventive care for high-risk women. This study reports outcomes of 5,787 women with a confirmed BRCA mutation who at study entry did not have ovarian, fallopian tube, or primary peritoneal cancer and completed a baseline and at least one follow-up questionnaire. 47% of subjects had a prior history of breast cancer. Reported outcomes included cancer risk reduction following oophorectomy, all-cause mortality, rate of primary peritoneal cancers following oophorectomy, and survival following clinically identified cancers, occult cancers identified at oophorectomy, and primary peritoneal cancer following oophorectomy. Strengths of the study included the very large cohort with known mutations, prospective study design, and confirmation of all cancer diagnoses with pathology reports or medical records. The most notable finding for women who underwent preventive oophorectomy was a 77% reduction in all-cause mortality, due mainly to the reduction in ovarian, fallopian tube, and primary peritoneal cancers, but also partly due to the reduction in breast cancer incidence and mortality. In an earlier cohort of 2,482 BRCA mutation carriers, Domchek et al. In JAMA 2010 reported a similar reduction in all-cause mortality associated with oophorectomy in BRCA1 carriers, but a non-significant reduction in mortality for BRCA2 carriers. The current larger study confirms a similar reduction in mortality for both BRCA1 and BRCA2 carriers, which was equally applicable to women with and without a previous history of breast cancer. Finch et al. Point out that the relative youth and short follow-up of the cohort, with a median entry age of 46 years and follow-up of 5 years, increased the relative reduction in overall mortality, as younger women are expected to have fewer non-cancer deaths. It is likely that there will be an attenuation of the impact on mortality as the cohort ages and other causes of death become more common. And this could be particularly true if surgical menopause increases non-cancer mortality later in life. Therefore, long-term follow-up of the cohort and inclusion of mutation carriers of various ages will be necessary to determine the long-term impact of oophorectomy on mortality, as well as its benefit in older mutation carriers. Another important issue not covered by the current study is the role of hormone replacement therapy in optimizing mortality in young mutation carriers undergoing oophorectomy. The large size of this study allowed analyses based on age of oophorectomy, providing important data to inform clinical timing of the procedure and to personalize recommendations for BRCA1 versus BRCA2 mutation carriers. Current guidelines by the National Comprehensive Cancer Network, the NCCN, do not differentiate recommendations for timing of oophorectomy between BRCA1 and BRCA2 carriers. The NCCN recommends salpingo oophorectomy for both groups at age 35 to 40. But ovarian cancers in BRCA1 carriers are known to occur on average about 10 years earlier than those in BRCA2 carriers. Finch et al. Have shown that BRCA1 carriers that delay oophorectomy to age 40 have a 4% risk of ovarian or fallopian tube cancer, either occurring prior to or diagnosed at the time of oophorectomy. Therefore, it seems prudent to recommend oophorectomy at age 35 for BRCA1 mutation carriers who have completed childbearing. In contrast, only one BRCA2 carrier developed ovarian cancer prior to age 50. From an ovarian cancer perspective, it appears safe to delay oophorectomy until age 40 to 45 for BRCA2 carriers, though earlier oophorectomy would provide greater protection against breast cancer. Therefore, 35 years appears to be the ideal age for oophorectomy for BRCA1 carriers, regardless of their breast cancer prevention plan. In contrast, BRCA2 carriers planning prophylactic mastectomy can delay oophorectomy until age 40 to 45. But those not electing mastectomy might choose earlier oophorectomy to maximize reduction in breast cancer risk. Finch et al. Compared survival between clinically detected ovarian cancer, primary peritoneal cancer occurring post-oophorectomy, and occult but invasive cancers detected at oophorectomy. As expected, survival was much better for occult cancers, with a 92% 5-year survival. Clinically detected ovarian cancer and primary peritoneal cancers post-oophorectomy both had much worse 5-year survivals, 54% and 38% respectively. Unfortunately, the study did not have information on which ovarian cancers occurred in women on screening, but presumably, since all women knew their mutation status at study entry, many women were undergoing some ovarian cancer screening. Despite this fact, the relatively poor survival of clinically detected cancers emphasizes the importance of salpinga oophorectomy to reduce risk of cancer and death in women with BRCA mutations. An acknowledged limitation of the study was a lack of information on the inclusion of salpingectomy and the lack of standardized pathologic evaluation at the time of risk-reducing surgery. Consistent with the lack of complete serial sectioning of ovaries and fallopian tubes in the current study, only 39% of the occult cancers identified at the time of oophorectomy were identified in the fallopian tubes. In contrast, studies with detailed pathologic evaluation of the specimen report 80 to 100% of occult cancers to originate in the fallopian tube. Therefore, it is likely that a number of occult fallopian tube cancers were missed at the time of surgery. Occult cancers missed at the time of oophorectomy are likely to present clinically within a few years of surgery as a primary peritoneal cancer, which would both raise the reported rate of peritoneal cancer post-oophorectomy and reduce the apparent efficacy of the surgery in preventing such cancers. The 5-year survival of primary peritoneal cancer post-oophorectomy was poor at 38%, which points out the critical importance of maximizing identification of occult cancers at the time of risk-reducing surgery. A detailed surgical pathologic protocol for all risk-reducing salpinga oophorectomies should include pelvic washings for cytological evaluation, complete removal of the fallopian tubes, and comprehensive serial sectioning of the ovaries and fallopian tubes. Furthermore, while treatment details were not reported by Finch et al., other studies have pointed to the need for adjuvant chemotherapy following identification of occult but invasive fallopian tube carcinomas in BRCA1 mutation carriers. At the present time, the risk of primary peritoneal cancer in BRCA mutation carriers who had negative pathology associated with such a detailed protocol and had complete removal of the fallopian tubes remains uncertain. Nearly 20 years after clinical testing became available for the BRCA1 and BRCA2 genes, Finch et al. Have reported important outcomes to inform the use of oophorectomy and personalized recommendations for BRCA1 versus BRCA2 mutation carriers. I applaud the international effort that has gone into this large prospective registry. Undoubtedly, many more important clinical insights will be provided by the Hereditary Ovarian Cancer Clinical Study Group with longer follow-up of this cohort. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.